All right, let's take a quick look at the structures, the vital important structures that underlie the clavicle. In general, if you see something large and it is yellow or blue or red, and it could possibly be injured, that would be bad. In this case, it's obviously we have the vein, which we're somewhat worried about, but not particularly. Though it can cause some venous congestion return, which can be an issue, which we've talked about in the past. The artery is the primary one we're concerned about, and finally the nerve. So let's sort of talk about briefly how these things can be injured. All right. So remember, venous is a low flow system, so it doesn't take much pressure to decrease venous return, which then causes a back pressure ischemia. The arteries, obviously, arteries supply the blood downstream to all the muscles and tissues below that area, especially at the level of the clavicle. If the artery is injured, if there's an intimal tear, if there's compression, you're going to start to see ischemia in the whole upper extremity, which obviously is a bad idea. And finally, the nerve. Now, interesting things about nerves is nerves can have a contusion, which is essentially like hitting your funny bone, so you have a force that then relieves that. This, surprisingly, the tissue over here is sort of stunned but not dead, and this will recover relatively rapidly. On the other hand, you can actually have a significant injury where there's constant pressure in that area. And you have constant pressure, again, it doesn't take too long to decrease the blood supply to that area, and instead of being contused, this area just basically necroses. And that would be bad, especially for a nerve that high up. By the way, I'm sure somebody's going to say something, but just ignore this whole thoracic outlet syndrome. It was the best picture I could find with fair use. But this discusses the anatomy, which is relevant, but we are not talking about a thoracic outlet syndrome. Now, with a clavicle fracture, or clavicle injury, it's easy to focus simply on the clavicle, but keep in mind that there's a joint midline and a joint laterally. And for the sake of thoroughness and not to look like a yutz when you miss it, you want to actually address all three of them. Everyone head straight for the clavicle, which is obvious because we're talking about clavicle fractures. I would recommend not doing that. I would go from the middle and work your way out. And so this would be the sternoclavicular joint. Right. Your clavicle obviously is over here, and your acromioclavicular joint is over here. So 1, 2, 3. Work your way from the middle and go out. We'll do a brief overview, and then we'll go to some of the anatomy really quickly. The sternoclavicular joint, this one over here, is important. Number one is it tends to get missed, and later on the patient has significant pain. It gets missed. Somebody finally makes the diagnosis, and generally the patient, or more importantly, the parent, is not happy. So again, when you palpate this, and you should palpate every shoulder and clavicular injury, start in the midline, work your way out, palpate the clavicular joint and document that it's not tender, palpate the length of the clavicle and document that it's tender or not tender, and finally palpate the AC joint and document whether it's tender or not tender. And here's the reason for this, is that you'll frequently get an x-ray and the clavicle itself looks good, and nobody palpates the sternoclavicular joint or the AC joint, and the patient has pain, and you send the patient home and say there's nothing wrong with it, the x-rays look good, not taking into account the fact that you have a ligamentous injury and they have a significant AC or a significant sternoclavicular joint injury that would have significantly improved with physical therapy, and instead it's missed. So let's address each of these individually.